Hello, and welcome to the Wilmot Cancer Institute Community Conversations on Cancer series, sponsored by the Office of Community Outreach and Engagement and its Cancer Community Action Council. My name is Candace Lucas, and it is my pleasure to introduce today's topic and our amazing speakers. Community Conversations on Cancer is an education series designed to partner community experts with health professionals to educate, exchange ideas, and disseminate information on cancer, research, and health disparities. Through this format, evidence-based perspectives on the continuum of cancer care and research will be highlighted, along with the lived experience of our community partners and experts. Topics will address the social determinants, improving healthcare delivery, reducing health disparities, and increasing research participation from underrepresented groups in order to decrease the cancer impact across our 27-county catchment area. This month's discussion will focus on what you need to know about colorectal cancer, treatment options, the disparities that exist, and what you can do about it. This live event has been approved for 1.0 AMA PRA Category 1 credit and 1 contact hour for social workers by UR's School of Medicine and Dentistry, accredited by the Accreditation Council for Continuing Medical Education. Throughout our presentations, feel free to enter any questions in the Q&A box located at the bottom of your screen. If you would like this question directed to one of our speakers, please include the speaker's name in the question. And now I'd like to introduce our two speakers, Ms. Quarnisha White, who's a board-certified nurse practitioner and joined the Division of Colorectal Surgery. She was born and raised in Rochester, New York. She earned her undergraduate degree in nursing at St. John Fisher College and joined the University of Rochester Medical Center as a bedside nurse in 2011. While in this role, she expanded her career to include nursing leadership. After receiving her master's degree in 2017, she continued within URMC as a nurse in the Division of Colorectal Surgery. She is proud to care for patients both in the hospital as well as in the colorectal clinic. Her passions include patient engagement, education, screening, and prevention. In October 2021, Q further expanded her career and became the first advanced practice provider diversity, equity, and inclusion officer for URMC. Her mission is to create an environment where each patient is given the same opportunity to engage with URMC's healthcare system. Our next speaker will be Mr. William Joe Lightfoot, fondly known as Willie throughout his community. He's a native son of Rochester, New York, where he has continued to wear many hats. Mr. Lightfoot has been married for 25 years and is the father of 4 children and grandfather of 3. He is a U.S. Air Force veteran and retired Rochester fireman. He has also served as a former Monroe County legislator. He currently serves as a city council member at large and was previously the vice president of the Rochester City Council. He also proudly served as the Monroe County Democratic Committee district leader of the 25th Legislative District. Mr. Lightfoot has served on a number of committees, including holding the position of head chair of the Rochester Public Safety Committee and as a commissioner of the Rochester and Monroe County Racial and Structural Equity Commission, honorably leading its Business Development Committee. In addition to all of this, Mr. Lightfoot is a New York State licensed barber and barber examiner. Mr. Lightfoot himself is an entrepreneur and the developer and owner of a large multi-purpose building and land space known as Lightfoot Square, where he is the owner and operator of New Creations Barber Unisex Shop. He is also the president and founder of the United Professional Barbers and Cosmetologists Association. Mr. Lightfoot founded the annual Cut the Violence Free Haircut event and Rock Against Gun Violence Coalition in order to have the mental and physical energy as well as a continually renewed spiritual drive and determination to gracefully balance wearing all of these hats. Mr. Lightfoot serves as a pastor of Prayer House Church of God by Faith, located in downtown Rochester, New York. After we hear from these two amazing speakers, we will turn this over to our facilitator, Ms. Ronalyn Pollock, who is co-lead of the Cancer Prevention and Risk Reduction Working Group of the Cancer Community Action Council. And she will lead our distinguished panel to answer any questions you may have. So with that, I will turn it over to Ms. White.
Thank you. Good day, everyone. I'm so glad that everyone was able to join us today. I'm just going to share my screen. Okay. So we're going to talk about colorectal cancer and community health. My name again is Quarnisha White. Most people call me Q, and I work with colorectal surgery and am the Diversity and Equity Inclusion Officer for the advanced providers at Strong Memorial Hospital. So what is colorectal cancer? It's a cancer that presents in the colon or the rectum, which is the last part of your digestive system, as you can see right here. And it starts out as a polyp, which is just a small growth, which is non-cancerous, that over time can become cancerous. Screening, a lot of people think that it's at the age of 50, but I want to tell you that 45 is actually the new 50. Average screening begins at age 45 to 75 if you have average risk. It continues past that depending on your risk factors and usually stops around the age of 85. The most important thing is that screening saves lives. When caught early, colorectal cancer is one of the most preventable and treatable cancers. Screening. So the gold standard, meaning the number one screening tool that we have that gives us the most knowledge, is the colonoscopy. So it allows direct visual inside to your rectum / colon using a tube, which is connected to a light and a camera. You are given sedation for this. During this process, if there is a polyp, it can be removed during the procedure. It does require a bowel prep so that we can visualize your colon, and it gives the most accurate results. Typically, it's done every 10 years, but it can be done sooner depending on the findings. Further screening includes a sigmoidoscopy, which is similar to a colonoscopy. However, it only views the left side of your colon, so this side here. It requires still a bowel prep. It can be done without sedation, and usually it's every 5 to 10 years, again, depending on your results. A CT colonography is a virtual colonoscopy. This is done with a CT scan, which is a special X-ray. It visualizes the colon with 2 or 3D images. It still requires a bowel prep and is every 5 years. Furthermore, outside of that, there are tests that you can do from home. So stool sample tests that can be sent to the lab. There are a few different types. Some of them, you collect your bowel movement and they test the blood that comes from a polyp or a tumor that might be present, and some tests for abnormal DNA in your stool. This can be done every 1 to 3 years and is based on the testing and can be done in your home. If there are any positive findings, however, you will need to still follow up with a colonoscopy. So remember, don't flush and you might actually save your life. Symptoms are so important to know. So changes in bowel habits, that can be diarrhea, it can be constipation, it can be change in the actual shape of your normal stool, blood that's in your stool, or painful bowel movements. Abdominal cramping, gas, bloating, nausea. You can have fatigue, loss of appetite, weight loss. But most importantly, you have to understand that cancer in its earliest stage often does not have any symptoms at all. Are you at risk? So do you have a personal history, meaning a personal history of colorectal cancer, or if you have polyps in the past? Have you been told that you have an inherited colorectal cancer syndrome, such as FAP, MAP, or Lynch syndrome? Have you ever had radiation to your abdomen or pelvic region due to a previous cancer? Do you have a family history of colorectal cancer, like a sibling, a parent, a grandparent? Are you over the age of 45? Are you a smoker? Are you a part of the following ethnic groups? So American, meaning Alaskan, Black, Native, or Jewish people of Eastern European descent. If you answered yes to any of these, then you may require earlier screening than the age of 45. Let's talk about some colorectal cancer facts. Colorectal cancer is the third leading cancer in the US. However, it is the second cancer leading cause of death in the US. It is also has a lifetime diagnosis risk if you're a man, 1 in every 23. If you're a woman, 1 in every 25. Rectal cancer is higher by 25% if you are a man than a woman, and 1 in 3 eligible adults are not getting screened despite knowing these facts, or maybe they aren't aware. For this year alone, there is estimated to be 151,000 people who are going to be diagnosed. Of that, 18,000 are going to be diagnosed younger than the age of 50. If you're a millennial, you are 2 times more likely to get colon cancer, 4 times more likely to get rectal cancer than a baby boomer. And there are going to be approximately 52,580 deaths related to colorectal cancer. And to give you some perspective, the Buffalo Bills Stadium fills 71,000 people. So that is a lot of people. The good news is that there are good survival rates if you are diagnosed at a local disease. Your survival rate can be greater than 91%. However, if you're diagnosed at a later stage, it can drop below 25%. The most important predictor of survival is the age at the time of diagnosis, but there are currently 1.5 million colorectal survivors in the United States. We're going to switch gears a little bit because I really want to talk about our most vulnerable population. So everyone knows who Chadwick Boseman is. He died at the age of 43 to colon cancer. Our most vulnerable population is Black America. The fact is that colorectal cancer disproportionately affects Blacks more than any other ethnic group for multiple reasons. It is despite Black America is the third largest racial ethnic group in the US. However, they have 20% more likely to get colorectal cancer, and they are 40% more likely to die from it. Black men, they are less likely to get screened, and when they get screened, they're diagnosed at later stages. This is not good because of the fact that when you're diagnosed at a later stage, your mortality increases and what we can give you for treatment is limited. Having the lowest rate of survival rate than any other population, and a death rate if you are a Black man is 40% higher than any other population. Remember that men in general have a 25% increased risk. Further facts for 2022 related to the Black America. There are going to be approximately 20,700 new cases this year and about 7,200 deaths with Black people related to colorectal cancer. Our most common cancers among this group are prostate, lung, then colorectal if you're a man, breast, lung, then colorectal if you're a Black woman. The leading causes of death are approximately lung first, then prostate, then colorectal, breast, lung, and colorectal if you're a Black woman. But why is there such vulnerability? It's not because you're Black. That is not the answer. There are systemic racial disparities that are within this subgroup. Lower paying jobs, lack of access to healthcare and affordable food, low quality education, unsafe housing environments. There are lower cancer screenings, which has lack of health related to lack of health insurance, lack of consistent primary care providers, and significant medical mistrust. These are all known as health disparities. Health disparities result in an increased obstacles that affect prevention, your detection, your treatment, and your survival. It also increases your likelihood of being diagnosed at an advanced stage of disease, which is then more costly and more difficult to treat. You're more likelihood to have a delay of treatment and not receiving the actual recommended treatment. Can you reduce your risks? The answer is yes. Lifestyle, healthy lifestyles, including smoking, is really huge. If you quit smoking, you have a better chance of survival. There is a 50% higher risk factor of colorectal cancer if you are a current smoker. Limit alcohol consumption to 1 to 2 drinks a day, making sure that you're drinking plenty of water, 8 ounces glasses a day, drinking low-fat or fat-free milk, exercise regularly. This can be simple as walking outside around your neighborhood every day, maintaining a healthy weight, eating lots of fiber, incorporating fruits and vegetables into your diet, including whole grains into your diet, decreasing your consumption of fried foods and excess sugars, eating the more lean meat, staying away from the red meat, so your chicken, your turkey, your fish, limiting processed foods, hot dogs, lunch meats, and most importantly, monitoring your bowel movements. Become very comfortable with looking what's coming out of you. And if it doesn't look right, seek medical advice if there is a change. Thank you.
Okay, hello, good afternoon, everyone. I want to thank all of those who, Wilmot Cancer Center, and all of those who have made this possible to be able to have this critical conversation that literally can save lives. My bio has been read, so I won't go over, who I am. Many people kind of know some of the work that I've done in this community. But I want to speak in perspective to my lived experience as it relates to colorectal cancer screening, and as it relates to me taking a proactive approach to be raise awareness and education around it in the spaces that I'm in. And, as a barbershop owner, as a pastor, as just a leader in my family, which many of us all are, we're leaders in our families, and we should be looking to do all we can to make sure that we have a healthy life. Health is wealth, right? So I think that it's very important that we do everything we can to make sure that we're living a healthy, prosperous life. With me, my history, my father, the late Honorable Willie Walker Lightfoot, passed away very young. He was 60 years old. When he died, he succumbed to stomach cancer. Now, he didn't die of colorectal cancer, but he did die of cancer. So that word, many of us hear that word, and we can really cringe because many of us have suffered family losses that we've had far too soon. We all wish we would have more time with our loved ones, and I'm one of those. My father was my best friend. He died very young, and he was the type that didn't want to go to the doctor. He just, like many African-American males especially, that just don't want to do regular checkups and go to the doctor, and especially when it comes to procedures as invasive as colorectal cancer screening. And so there are some things that, that's only for the exit, you know what I mean? And people just have an issue with that. Being in the barbershop, it was brought to me to do some awareness by Dr. Marino. Ms. Sizer came to me and wanted to discuss about having some awareness. I initially had, some thoughts about it, and I said, you know what? I'm in a position where, I believe in, spending 20-something years in the Rochester Fire Department. My whole life has been around helping to save people's lives. So I'm like, and once they said the word cancer, I was all in. I want to do anything I can to prevent someone else from potentially having a loss to cancer. And so we began to have some educational and awareness sessions in my barbershop. And as a result of that, many signed up to take the colorectal cancer screening, to include myself. And I had some fears. And we had conversations in the barbershop. There are 3 things that people normally don't change in their life. And that's their doctor, their spiritual leader, and their barber or beautician. So people tend to share things with us that they normally don't share with others. And we were having some very detailed conversations about this. And I said, you know what? In order for me to get rid of my own fears, I should sign up myself, do it myself, I spent the night in the hospital. I've never had stitches. I've never had a broken bone. I've never been under sedation. So these were some of my fears. And I thought that also because I'll be turning 50 this year, that I wasn't 50, that I didn't have to take it yet. And I found out through the education and the awareness, Dr. Marino and Ms. Sizer coming into the shop doing the awareness with us. And I recommend getting that awareness if you do nothing else, if you're a pastor, if you're a leader, if you're a community person, to get this awareness for, not only did we do it in our barbershop, but we also did it in my church as well. And I found out that 45 was the new 50. And so I signed up to take the test. Many of my fears, my wife had taken it before, and she was like, oh, you got to drink this nasty stuff and you got to go through all of these things. And I found out that things have changed over the years. I was able to drink Gatorade. The experience of the prep was not that difficult. It was not that hard. My fears of being under sedation was not that bad. I actually didn't even recognize it was some of the best sleep I ever got. I never felt any pain. It was very quick. The whole procedure was very smooth, and everything just went very well. And then they did find 3 polyps in my particular procedure that were benign. And I was also told that it was as a result of us signing other individuals up from within the barbershop, that there were some where they found polyps that were actually cancerous. So I looked at that as, a win. Like, what, we potentially saved somebody's life from potentially that going and becoming cancer and them having colorectal cancer. And so I just wanted to continue having these educational sessions around our community. I wanted to be a part of all that we can do to continue to raise awareness and be preventive. This is a preventable cancer. It can be prevented. And I think that folks should, especially as African-American males and men, we have to encourage one another to do better about our health. We all know the health disparities that are out there, especially as it relates in regards to people of color. And I think we have a duty to one another to educate, to encourage, to help to raise awareness about how can we put ourselves in a position where we can be here as long as we possibly can for our families and our community. And so that was kind of my experience in regards to colorectal cancer screening. We've been having more conversations around it. Many came back in my shop and in my church, came back with positive feedback, like I had a positive experience, which encouraged others, whether they were in their spaces and in their circles, to consider colorectal cancer screening. And I think if nothing else, it is important and imperative that we continue to raise awareness from this preventable cancer. And I can only think about what could have happened with those 3 polyps that were found in me had I ignored this awareness, had I not gone and got a colorectal cancer screening based on my fears, and then go on throughout my life, and this thing could turn out to be something that could be deadly. So, I'm glad to be a part of this panel. I look forward to the questions. I look forward to the education that we receive from individuals' questions and the answers. And I'm here to offer any other information about my particular experience. And I'm grateful for being here. So thank you.
Right. Thank you, Willie. So we are now at the panelist portion of our community conversation. As Candace had indicated earlier, I'm Ronnie Pollack. I serve as co-lead of the Primary Prevention and Risk Reduction Work Group with the CCAC, which is Community Cancer Action Council with Wilmot. So I will give a brief introduction introduction of our panelists, I'll be helping to kind of field some of those questions. So as I'm doing so, attendees, this is your time to put your questions in the Q&A portion of the webinar, the Zoom webinar here. So when you have questions, you want answers to them, feel free to put those questions up in the Q&A section. So first, we have Dr. Danielle Marino, a gastroenterologist who is passionate about colorectal cancer screening and prevention and genetic testing to figure out risk. Next, we have Dr. Lisa Cannon, a colorectal surgeon that believes in coming up with treatment plans with patients so they are active in all decisions, like that. Dr. Maria McGreevy, a third-year medical fellow in medical oncology. Next, we have Dr. Christopher Walker, a second-year fellow in gastroenterology. And lastly, we have Ms. Hannah Farley. She works in the Cancer Services Program of the Finger Lakes to make sure that the uninsured and underinsured receive free cancer screenings. So the first question that I will put out there, this is for colorectal cancer surgery for our panelists. And again, welcome panelists. So the question is, my father has to have part of his colon removed. What can we expect for recovery and how do we help?
Sure. Thank you, Ronnie. So surgery for colon cancer can almost always be done minimally invasively nowadays, meaning using either the laparoscopic cameras and long instruments or the robotic cameras and instruments to be able to remove colon cancers through small incisions, which makes recovery faster. From a family perspective, you can expect your loved one to be in the hospital somewhere around 3 to 5 days. When they first go to the recovery room, they'll be a little groggy. We'll get some pain medication and sometimes need some nausea treated. And then as they start to feel better, they can start to take liquids and then food. Your loved one can leave the hospital when they're walking, eating, urinating. Their pain is controlled with oral pain medications only, and that there's no signs of complications. Once you bring your loved one home, you can expect that they'll be able to walk around. They'll be able to carefully navigate stairs. They will not be bedbound. In fact, we discourage that. Walking is good, but they're going to need help and encouragement, and assistance with meals, frequent smaller meals, and that sort of thing.
Yes, so I'll just key on that. You also get to meet me, Q, the nurse practitioner, and my amazing partner, Holly. You have a multidisciplinary team. So we are with you from the day in surgery with your surgeons until afterwards, where you have a social work, you have the PT, you have your nurses. You're never alone. Even during these hard times where COVID has really restricted visitors and loved ones in the hospital, just know that your loved ones are very much so protected by their colorectal team and patient. We love you guys like we're family, and we will get you through. And like she said, through that 3 to 5 day process. So yes.
Great, thank you. Another question I'm seeing, is there genetic testing available for colorectal cancer?
I guess I can take that one. So yes, there absolutely is. And depending on at what age you get the colon cancer, what it looks like under the microscope, you may need genetic testing to see if you and your family members are at higher risk. We actually have a hereditary cancer program here through Wilmot. It's housed at the Pluta Cancer Center, where any patients who have a strong family history or a diagnosis of colorectal cancer can be seen by one of our great nurse practitioners and genetic counselors to kind of talk about your personalized risk and decide if genetic testing is important for you, and then also help you kind of navigate the screening and surveillance recommendations in terms of how frequently do you need to get your screening, or are there other cancers that you might be at risk for, things like that. Colon cancer is actually associated with other types of cancers as well in certain syndromes. So for instance, a syndrome called Lynch syndrome has a higher rate of colorectal cancer, but also other cancers like uterine or ovarian. And so it's important to find out all of that information about what kinds of cancers run in your family and to bring that information to your doctor. And your doctor can help you figure out, are you at higher risk? Do you maybe need to be seen in our hereditary cancer screening and risk reduction program? And are you someone that might actually be eligible for genetic testing?
Great, thank
Anything
you.
to add to that, Dr. McGreevy? Dr. McGreevy will be working with me in that program as well. So hopefully I've covered the basics of that information.
Yeah, no, I think so. I was just going to say, just make sure that whoever your healthcare provider is aware of your family history, because even things that don't always seem to make the most sense in terms of cancers that run in families, sometimes there is more rare conditions. So definitely make sure that they know of all the cancers. And if there's any question, the hereditary clinic is always happy to see folks to help to decide if genetic testing is needed or not.
All right, great, thank you. Another question from one of our attendees. I was told I have to get screened every 2 to 3 years. If it's slow growing, why do I need to get screened so frequently?
I can take this one. Usually when someone has to be screened more frequently, it's usually related to either what's found on the colonoscopy or the person's family history. So people who have polyps that develop, depending on the type of polyp and the size of the polyp, will need to be screened more frequently because they've already demonstrated that their colon is producing these polyps, and they are at higher risk of producing another polyp that is either of the same category or even more concerning. So it's important for those individuals to be screened more frequently, so that any polyp that develops in the future is caught early before anything more concerning happens, any transition towards cancer, etc.
Great, thank you. All right, this question might be for Hannah Farley, but feel free, all the panelists, weigh in if you have anything. I have a high deductible plan and have heard about people getting a bill after they go in for a screening. Why is that?
So most health insurance plans will cover the cost of a colon cancer screening. The concern, I think, is if there's polyps found, if there's additional work needed, that may then produce a bill for the patient that's beyond that bill just for the colon cancer screening. If anyone wants to weigh in more on that, I'm by no means an insurance specialist.
Yeah, I'd love to join in on this conversation. So the Affordable Care Act does say that all preventive services need to be covered in full. And unfortunately, there is a loophole sometimes where if a polyp is found and we remove it or we take biopsies of something else, that the insurance companies will then change that to a diagnostic procedure, and then cost sharing by the patient is imposed, meaning you might have to pay some of it towards your deductible. That is unfortunate and something that is being worked on at the federal level. Actually, just a few months ago, the Federal House of Representatives did pass a bill to try and stop that from happening, because truly it should be the intent of the exam. If someone comes in for screening, they should not have to pay anything. It was screening. The point of screening is to find polyps and remove them. So you shouldn't have to pay for that. But sometimes it does occur. And if it does, there are ways to try to appeal that. There are ways to go about that. If you go to getscreensrochester.org, there is an example of an appeal letter on there that you can send to your insurance company to try and appeal that bill. And the other thing is, Hannah's program can help those patients that do have concerns for maybe not being able to cover a bill if it does come your way after the fact. But it's important that you link with the Cancer Services Program and enroll beforehand, so that if you are what we call underinsured, meaning you have insurance, but you might not be able to actually afford the high deductible, then the Cancer Services Program could help you with that. So Hannah, do you want to tell them a little more about your program and how to get enrolled?
Yeah, so thanks, Dr. Marino. The Cancer Services Program, we do pay for colorectal cancer screenings as well as breast and cervical cancer screenings for the uninsured predominantly, and also the underinsured based on needs. So to enroll for our program, if you're worried about paying for a colorectal cancer screening, the best way to enroll is to just call us at 585-224-3070, Monday through Friday, 8 a.m. to 4 p.m. And you'll speak with us. We'll go through a little enrollment process. It takes about 5 to 10 minutes. And then we'll send you a consent letter just for you to sign to consent to us paying for your services. So that's kind of the quick and fast of it.
Great, thank you. This is a question specific to Ms. White. Why do millennials have 2 and 4 times greater risk of colon cancer and rectal cancer, respectively, than baby boomers?
So I think that's in relationship to the fact that colorectal cancer in general, you're finding at a lower age range than you were before. You have to remember that 45 is now the new 50, and it was never that before. There were higher starting points where we actually did screening. So part of that, again, when you look at the last part that I talked about, lifestyle, what are we doing differently that we weren't doing years ago? Also family history, things like that. And also the fact that colorectal cancer has more awareness now. And the fact that we are able to screen more people now, we are finding it earlier. So it may have had a higher rate before, maybe we just weren't catching it because the screening started at a higher age. But if anyone else wants to chime in as well on this, go ahead, Dr. Cannon.
Thank you, Q. To add to that, so the colon cancer rates are trending into younger and younger patients. We don't know exactly why that is. We believe it's multifactorial, meaning it's because of a number of reasons. Some of those reasons are probably environmental exposures to more chemicals and other things that are in the environment that perhaps weren't there decades ago. A tendency towards a more obese population as a whole, a more sedentary lifestyle, and probably several more factors that we can't pinpoint. In addition, younger folks tend to be diagnosed at a later stage, meaning a more advanced cancer than older patients. And the reason for that is probably because the patients and their loved ones and their doctors aren't thinking of colon cancer in a 30-year-old. So a very typical story we get in our colorectal office, unfortunately, is a patient who was self-treating or working with others to treat something like hemorrhoids for a number of years. And unfortunately, we take a peek and do an exam and realize that they actually have a fairly advanced rectal cancer. And so that's why Q highlighted for you how important it is to reach out to your provider if you notice a change in bowel habits, especially persistent bleeding.
Yeah, I agree. I had a similar story that we had recently too, where a person had a change in their bowel habits. They noticed that their stool was coming out a little bit more thinner, and they were just like, I don't know what to make of it. But it wasn't until they ended up in the emergency department with significant abdominal pain that led to further testing that, again, they were younger, they were in their 30s, and that testing led to finding that they were at a higher advanced stage because, again, you guys have to look at what's coming out of you. And I can't stress that enough. Like, get comfortable with looking at your poop. You look at everything else, look at what's in the toilet. If something has changed, I stress that you have to talk to your doctor. If you don't have a doctor, talk to someone who you trust. Just no matter what you do, if we can, this is the most preventable cancer if we can catch it early. So again, stressing screening is the number one key that we can do.
Great points by both of you. I just wanted to add too that, you know, we are taking this more seriously these days because we're seeing these alarming trends of younger people. And so I wholeheartedly agree. You need to pay attention to your body. And if you have symptoms, you need to talk to a doctor. You know, a decade ago, if I saw a 30-year-old person with rectal bleeding, we probably would have said, okay, treat hemorrhoids, go home. These days, we take it seriously. If there's any bleeding, we're going to look, because you can find cancer in these young patients, and we're not going to just chalk it up to hemorrhoids. We need to, that's not something we want to miss. So definitely talk to your doctor if you're having any concerning symptoms.
Great, thank you. All right, next question for Dr. Marino and Dr. Walker. What guidelines are you currently following for surveillance of CRC screening for those with first-degree relative with colorectal cancer? And what is criteria for genetic testing?
I can start, and I guess Dr. Marino can talk after me. So if someone has a parent or sibling with colorectal cancer that was who was diagnosed prior to the age of 60, that person should have a colonoscopy starting at age 40 or 10 years before that their parent or sibling was diagnosed. So if their parent was diagnosed with colon cancer at age 45, then the child should start having colonoscopies at 35. And then if that colonoscopy is normal, that person should have colonoscopy in 5 years. The findings on the colonoscopy will otherwise determine how frequent the colonoscopy should be. So if there are polyps, it might be another colonoscopy in 3 years, or so on and so forth. But the longest interval, if their family history is, as I described, is going to be 5 years.
Great, excellent. I would just add that for patients who have a significant family history, those alternative screening options that Q talked about, including the stool test, flexible sigmoidoscopy, all of those are not options. So if somebody has a significant family history, as Dr. Walker described, below the age of 60 and a parent or sibling, colonoscopy is the only appropriate screening exam. In addition, there are other, variations of family history. So in general, if you have, a grandparent or a distant relative who's diagnosed at an older age, that doesn't necessarily put you at a higher risk, and you would be screened as average risk. To answer the second part of the question of what is the kind of guidelines of when we would do genetic testing, there are many different ones, but in general, if you have more than 2 family members with the same kind of cancer, especially if one is diagnosed before the age of 50, then you definitely would meet criteria. Or if you personally are diagnosed with basically almost any cancer below the age of 50, then you would be considered for genetic testing as well. Dr. McGreevy, anything to add there's a lot of details of genetic testing, but just the basics, I think, having more than 2 family members with the same cancer or a Lynch-related cancer would be concerning. Anything else to add there?
Yeah, or if somebody's had multiple cancers, if one individual has had multiple cancers is another reason. But if you're the kind of person that says, cancer runs in my family, it seems like there's a lot of relatives and you're concerned about it, it's certainly something that we're always happy to help evaluate either at the hereditary clinic or something to just bring up with your primary care doctor, and they can help figure out and point you in the right direction in terms of how to get the genetic testing done. I think maybe just a quick moment to talk about the genetic testing because we talk about it, but it may not be clear what exactly that means. So just to give you all an idea, it's either a blood test that's just a vial of blood, or it's a saliva test that we can collect right in the clinic, or even if you live a distance from Rochester, we're able to mail out the saliva kits in the mail. And you provide your sample, and within about a month, we check certain genes that could be associated with cancers or increase your risk of cancer. And within about a month, we have the results and can talk about what those mean in terms of what your risk is and how it could potentially change what we would recommend in terms of things like the screening interval or other screening tests for other cancers that you could be at risk for as well.
Great, thank you. Here's a maybe just a basic procedural question. How does the colonoscopy work, and what happens when you go in to be screened?
Yeah, so essentially, I guess I'll start with after the person has done the prep, since the question is more about the colonoscopy. So after the person's done the prep, they've shown up for their procedure. They are the physician and the nurses talk to them about the procedure once more, make sure everyone has a clear understanding of what's going to happen. Then once they're taken to the procedure room, they're given some medications that will make them sleepy. And depending on the scenario, there are different, we'll just say different cocktails of medications that can be given depending on how sleepy a person will need to be. So there will be some medications that will make the person sleepy, and then once that's done, then the proceduralist, the physician, will do the colonoscopy and go in, take a look at the entire colon, and examining on the way out and remove any polyps that might be present, and taking biopsies or small samples of tissue if there's any abnormal appearing tissue that needs to be examined under the microscope. So then any sample that's taken during the procedure is sent to the pathologist, who's another physician who looks at everything under the microscope and comes back with more information about that tissue, usually after about a week or two. But after the procedure, once the person starts to wake up from after receiving the medications, the physician will talk to the patient about the procedure, how it went, what they found. So you'll know right away what was found. And usually family members are involved during that discussion as well, just in case someone forgets what the conversation was about, because the medication can make you kind of forget things. In general, if someone were to not want much medication, and in other words, they didn't want to be that sleepy during the procedure, they could do the procedure with less medicine and feel very comfortable. And some of those people end up watching the colonoscopy on the video screen, and they find that interesting. So that's also an option for those who feel comfortable and well enough for something like that. But that's generally what the procedure is like.
Great, thank you. Another question, and maybe kind of like a follow-up question to that from one of our attendees. How long does it take to get screening results?
So we could tell the individual what we saw right away. So once they wake up, we can say we saw and removed 3 polyps, or we didn't see any polyps at all. And then the results in terms of how the polyp looks under the microscope usually can take 1 or 2 weeks, and that's after the pathologist, another type of physician, analyzes it.
All right, great, thank you. Another question for our panelists coming in from one of our attendees. Where can you get genetic testing in Rochester, and is it covered by insurance? If not, how much does it cost?
Yeah, I can answer this one too. We can send the link if it hasn't already been sent in the chat. In terms of genetic testing, you can certainly do it at our hereditary cancer screening and risk reduction program. You don't even need a referral necessarily to come to this clinic. If you call and say you're worried about your family history or whatever the case may be, why you want to get genetic testing, we can get you an appointment and meet with you and talk to you about it. The cost is dependent on if you meet the guidelines for genetic testing or not. So if you do meet the guidelines, then it's covered by your insurance for the most part. If for some reason it's not covered by insurance, for the majority of cases, the companies that do the genetic testing will pick up on the cost. If you do not meet the criteria for genetic testing and you still want it done and want to pay out of pocket, the total cost from the company is $250 would be what you would pay out of pocket for it.
Okay. Thank you. Another question from one of our attendees. What are the different treatment options for colon cancer other than surgery?
I can talk a little bit about this too. So sometimes depending on how early or late the colon cancer is found, besides just surgery, sometimes people will need chemotherapy as part of the treatment regimen in order to have the greatest risk or the greatest chance of curing the cancer. When cancers are found later on, we don't necessarily always do surgery, and we talk about chemotherapy as a way to treat the cancer wherever it has spread throughout the body. Sometimes for rectal cancers, which are sometimes treated a little bit different than colon cancers, we can avoid surgery completely by doing a combination of chemotherapy and chemotherapy with radiation in certain patients. So it's very much individualized in terms of when and how early the cancer was found versus how late in terms of the different treatment options. And it would all be obviously a discussion with you as the patient and with a team of doctors that includes both surgeons and medical oncologists who give the chemotherapy and the radiation oncologists who would potentially give radiation if those were options for you.
Okay. Great, thank you. Another question from an attendee. How often are changes in bowel function related to new food allergies or sensitivities compared to new colon cancer?
Take that. Depends on the type of changes in bowels, but most of the time changes in bowels are not due to colon cancer. They're due to something else, either a food insensitivity or not enough fiber in the diet, things like that. So most of the time it is not colon cancer. However, if there is a change in your bowels that is persistent, that is very different than what your normal is, and it stays like that for a while, that is when you need to talk to your doctor, especially if it's more constipation. That's the more frequent change in bowels that we would see, not really diarrhea as much, although it is possible as well. So if there's any change in your bowels that persists for a while and is not normal for you, that's something to bring up to your primary care physician.
Great, thank you. Another question from an attendee for our panelists. When encouraging patients to complete a colonoscopy, what is the estimated time for the patient to get the procedure scheduled?
Answer that one. It can be, for an average risk screening exam, it can take anywhere from 3 to 9 months to be scheduled. So if you're 44 and you know you need it next year, you can call now to try and get scheduled. However, if you're having symptoms or you have a family history or things that put you at higher risk, it is important that the doctor who's putting in the referral makes that clear so that you are triaged higher and done sooner. Or when you call to get the appointment, to make it clear that it's not just an average risk screening, you have family history or you have something else that it needs to be done sooner. But in general, when you call, between 3 to 9 months later is when you'll get your appointment for colonoscopy. There's a lot of patients over the age of 45 and not too many of us that do these exams. So there's a big demand.
And I'm sure too, coming out of a pandemic has probably put a strain on scheduling some of those procedures.
Yeah, a lot of people have put off their screenings, unfortunately, during the pandemic. And so it's important to get back in and get back to putting your health first, because we don't want patients being diagnosed with late stage cancer because they were avoiding these exams. So we're trying to get everyone in as quick as we can.
All right, thank you. This question for CSP. So the question is, say I get screened for free, but what if I need treatment after that?
Yeah, so if you get screened through our program, through the Cancer Services Program of the Finger Lakes region, we send you, let's say we send you a stool kit that you complete at home. It tests positive for blood in the stool. Then we're going to have you go for your colonoscopy. And if they find that you have cancerous polyps and you're uninsured, then we're going to help you enroll into the Medicaid Cancer Treatment Program, which is full Medicaid for the duration of your cancer treatment. And you do have to enroll into this program. So we're going to help you enroll into this program annually, just like you would a traditional insurance plan.
All right, thank you. I have a question specific for Mr. Lightfoot. What is the best way to engage the community in getting screened so that we can increase screening rates amongst Black males?
I think, great question. I think that interacting with individuals with the Wilmot Cancer staff and those individuals that are working to provide opportunities for education and awareness, I think is a start. I also think that we're also working to do things with the barber, beauty, appearance enhancement industry that is also promising as in regards to interacting with the community, using your houses of worships and your places where people tend to have the trust. Because one of the things with the health disparities that we're finding out, which causes these health disparities, is the lack of trust in the health system. And so you have to break down some of those barriers. And so those houses of worship, those places of appearance enhancement industry places tend to be places that are helpful. But we should definitely reach out to the individuals that are here on this call to set up opportunities to allow them to be able to come into your circles and to provide those awareness opportunities and education.
Right, great, thank you. And with that, I want to thank everyone for attending. A special thank you to our incredible presenters, to Ms. White and Mr. Lightfoot. Thank you to all of our panelists for your willingness to come on and bring your expertise and really be able to answer questions that our community has about this very serious topic of colorectal cancer and screenings. So thank you again all for attending our community conversation on colorectal cancer. If you would all please take a moment and fill out our post survey. It will help us choose topics of importance to you moving forward. And any questions that were not answered in the Q&A box will be answered by our panel and sent to all attendees, along with a link to the recorded session of this community conversation. Our next community conversation is scheduled for April 11th, and we will be discussing cancer health disparities. So hope you all can make time to attend then. Again, thank you everyone for coming out today, being a part of this very important conversation. Enjoy the rest of your afternoon. Bye-bye.